our second session has got another array of amazing talks, but just before we launch into our acne panel, I'm just going to follow up because there have been so many questions on the QR code, and you've all been very diligent at answering them, so we are going to answer some of these questions. So the first one is Hiva for you, and the question was, can sunscreen cause FFA, frontal fibrosing alopecia, and what's the evidence?
I haven't got my concept.
Let's see if there's a... Yeah.
Great question. Quick answer is we don't think so, so it's probably no. But it was when the physical filters were aerosoled, there was some link, but they've done 2 or 3 studies now, and there doesn't seem to be a link, so no to that one.
Great. Actually, while you're up here, thoughts on moisturizers containing SPF?
Not as good as SPFs that moisturize.
Great, I love this. Quick fire, let's go. I know you mentioned that UVB is as important as UVA for photoaging and pigmentation, but as there is 20 times more UVA than UVB, does it mean that overall UVA is still more important in the context of photoaging?
There's more UVA, but UVB is 1,000 times more damaging, so just remember it that way. So I think it just depends on the depth and how much it penetrates the skin. So probably both involved in photoaging.
You're done. Thank you so much, Hiva. Lucy, a couple of other questions for you and for AI. Somebody asked, with your system, if somebody reattends with the same lesion, does your AI compare it to the previous image?
No, it doesn't. So if they reattend, they would still go through the same pathway, but they would automatically be picked up by one of our audits, and it would go through to check that we were happy with the outcome.
Great. Somebody asked, what about incidental skin cancer findings during a top-to-toe exam? Could we risk missing the opportunity to treat early by not doing this and just photographing a solitary lesion?
Yeah, of course. You know, we know that this is an issue, and it's why there was a lot of kickback against doing teledermatology in the first place. But I think that we can see from the figures that were presented in the talk that we don't have that luxury, unfortunately. Patients are waiting over 12 months to come in for a routine dermatology appointment. And actually what we're talking about here is specifically about skin cancer, so a lesion of concern that's changing, that's been referred in on an urgent cancer pathway, and how we manage that. If we go around screening everybody, of course we're going to detect incidental skin cancers. And I can only say that I think through better education about skin monitoring, about sun protection is the only way that we can reduce that. Although, if we generate capacity through using AI, then we can free up time on that routine pathway to actually start getting to some of those patients that we know are there.
Brilliant. And last one, do you feel that AI will play more of a role in inflammatory dermatology as well as in skin cancer in the future?
I'm sure that it will. It's a much harder problem to crack, though, when it comes to inflammatory disease, because obviously there's so many more thousand skin conditions, and those skin conditions can look very different depending on the body site, the skin type, the stage of the disease. And so as a problem for AI to solve, that's a little bit more challenging. But I do think that AI will have more of a role in terms of being able to help us with perhaps some of the more mundane tasks in managing inflammatory skin disease, checking in with patients, looking after their sort of disease control, monitoring their medications and that side of things. And I think that that's something that we're likely to see much sooner. And I think we do have to think, how much do we want to give over to AI? I think when it comes to a lot of inflammatory skin disease, that's where our value is, isn't it? Seeing patients in front of us, giving a holistic approach, and that's what we want to create time for.
Thank you. And then Simon, just a couple, you haven't got away scot-free with the quick fire questions. So someone was asking, what about topical steroid withdrawal? Is this just a TikTok phenomenon, or do you think it's an actual entity?
It's not an easy question to answer, actually. It's both. It's definitely been amplified and blown out of proportion by social media. There is a small number of people that do appear to be suffering complications that are being classified as topical corticosteroid withdrawal. There's no clear definition of that yet. Some of those cases may just be the relapse of their eczema. So there's certainly more work that needs to happen to characterise that better. But the vast It's totally blown out of proportion, and the biggest challenge that we face is underuse of topical corticosteroids because of that fear.
Brilliant. And then just one last question, which may be the question of the day, and it's going to put you in a very difficult position. Someone has asked, not myself, CeraVe moisturizer versus Cicaplast in reducing total water loss and protecting the skin barrier. So they've asked you to pitch CeraVe against our lovely host, La Roche-Posay. What do you think?
I'm not sure I should be answering that one.
Hard to tell.
I mean, we've not done any testing on Cicaplast. That has a particular use case. It's more about tackling the inflammation associated with a wound to the skin. CeraVe is there to maintain healthy skin and correct that lipid defect. So it has that niche, well, I say niche, I mean, it's something that we need all the way through our lives and all the time to improve our skin condition. So if we are looking at improving our skin barrier, then CeraVe is the treatment to go with.
That was a good answer. Thank you so much, Simon. Fantastic. Thank you. Okay, so we're now going to move on to our acne panel, and I am really privileged to introduce our three guests. So please come and sit down, Faisal, Nikki, and Alison, and I'll introduce you as we go. So we're going to talk here about some really key parts of acne and our new the paradigms of treating acne, what we think the future looks like. And I'm really delighted to be joined by three professors, so a doctor amongst professors. And I've got Professor Faisal Ali here, who is a professor of dermatology. He's a consultant dermatologist and a Mohs surgeon, and he works between Manchester and London and is very, very widely published and very impressive with a list of publications and trials. We've got Professor Nikki Ralph, who works in Dublin, both within the hospital and also privately, and she has an interest in a number of different diseases, including photodermatology, and runs a centre in Dublin. And then we have Professor Alison Layton, who is a real acne guru, so she works in Harrogate, and has really, I think, set the tone for a lot of the way that we treat acne within the UK, and is often a person that I will ask very difficult acne questions to, hugely widely published. So really three very impressive people on our panel. So we're going to kick off with our first question. So let me get this up. And this question is basically for all of you, but I'm going to start with you, Faisal. And the question is about the shift of acne. So as we look at the landscape of acne management in 2025, from your perspective, what single scientific breakthrough or emerging therapeutic concept holds the most potential for UK and Ireland dermatologists?
I mean, for me personally, I think the fact that we're refocusing on the microbiome as a whole new treatment class for treating acne, so we can hopefully move away from being exclusively focused on antibiotics and possibly retinoids to this whole new treatment class, particularly in a time when there's an aversion to isotretinoin, a seeming aversion from a regulatory perspective with the rules from the MHRA, and also from some patients as well, which I'm finding, I'm sure all of us are finding on TikTok and Instagram, some teenagers, some of their parents just will not want to use isotretinoin, whatever you say. So it is exciting that we've got this new whole treatment class that can be used both topically and orally, and looking forward to learning more about that as the years go on. Fantastic.
So microbiome here. Nikki, what would you say?
Yeah, I mean, to reiterate that, you've got a lot of young people now who are really knowledgeable. They come in with all of their information often printed off, and they're talking about not wanting to suppress their gut, affect their microbiome long term. So they've had a discussion with their GP. They don't want to go on the standard antibiotics. And now we've got potentially new probiotic serums. All of this is very small numbers, but for people who have a mild to moderate acne, they may be the next thing that we're looking to, as opposed to just, here's your 12 weeks of antibiotics and let's hope it works.
Fantastic. And Alison?
So at the risk of being boring, I'm going to say the microbiome as well, but it's really interesting, isn't it? Because there was a real paradigm shift maybe a decade or so ago in terms of recognising acne as an inflammatory dermatosis. And, before then, we'd sort of thought it was due to blocked follicles, and nobody had really actually got honed in on what the integral problem was. So we've got seborrheitis. If you haven't got sebum, you haven't got acne. So we could find some new drugs to actually switch sebum off. That would be great, but we haven't got them at the moment. But it's an inflammatory dermatosis, and that really has led the fundamental scientists to start looking at the innate and the adaptive immune responses. And of course, Cutibacterium acne is a big driver of that. So I think what's really interesting for me is that we've now got dermocosmetics that have been shown to actually impact on the microbiome. And the other end of the spectrum, we've got phase 1 clinical trials looking at the safety of vaccines. And we've also got a little bit of interest, which I think is really worth watching, in biologics, because we know that C. acnes actually stimulate the inflammasome and produce IL-1 beta. So I think going forward, we've got the microbiome has got a whole spectrum of interesting areas that will come forth.
Absolutely. And that leads me nicely onto the second question, really about how we move that theory across to the way that we actually treat acne. So we do know that the microbiome has a really important role to play in acne, but how do we translate that sort of complex science into practical evidence-based recommendations? And I'm going to ask you about that, Alison, just leading up from what you've just said.
Yeah, it is very complex. I think that's the first thing to say. And it's interesting because years ago we thought that it was the quantity of C. acnes, as it was Propionibacterium in those days, that mattered. But with the advent of metagenomics and DNA sequencing, we know that's not the case. So it's actually due to the Cutibacterium strains. So we can find phylogroups, which we know are more likely to be seen in acne. And if we look at a strain level, we can see more virulent strains at that level too. So I think for patients, it's about saying this isn't about eradicating your microbiome. Antibiotics aren't great. We need to move away from that. We need to go for non-antibiotic preparations. We need to think about good skincare regimes which will actually impact on the microbiome. And we need to try and explain to them this is about adjusting your microbiome to a healthy state rather than one where you've actually got a microbiome which is causing issues.
Absolutely. And how much do we think we can modify the skin's microbiome by our gut microbiome?
Well, I think this is the big question at the moment, isn't it? I mean, there is evidence from dermocosmetics that you can actually stabilize the microbiome to a more healthy-looking appearance. We need to do more work to actually see whether that actually evidence is in terms of clinical improvement. I think that's one of the things we need to do. But if we look at what's happening with the acne vaccines, they are targeting antigens on the periphery of the Cutibacterium as well as virulent strains. So vaccines might in the future really help us address that microbiome, get rid of the dysbiosis and push us back into a healthy state.
Fantastic. And just you mentioned biologics. So is this things like lebrikizumab, or have you ever used biologics?
Well, there's been very little done with biologics. There's one small study that looked at an anti-IL-1 beta, and that did show some improvement, but not a huge amount. But there's a lot of interest in the acne world in terms of seeing how we can influence some of the adaptive and innate immune responses.
Fantastic. So moving on to what we have at the moment, optimizing combination therapy. So I think we all know now that sort of monotherapy, particularly topically, is not the best way that we can treat acne. And the concept of fixed dose combinations continue to evolve. What sort of practical benefits can you offer, like the busy dermatologist here, in terms of simplifying routines, enhancing patients' adherence? Nikki, what would you say about that?
Yeah, I think these have been a great evolution, especially when you've got teenagers who don't even want to wash their face, put their moisturizer on, and then you're asking them to do something in the morning, something in the evening, put this amount on here, put this amount on there. It's certainly been really helpful to kind of simplify the routine, and it makes it quicker for the dermatologist to be able to explain it. It's great that we've got synergistic ingredients coming together, whether it's your benzoyl peroxide with your adapalene, your tretinoin with your clindamycin. We've certainly seen that the vehicles that they've put them in are definitely more moisturizing. Whereas before it was really drying. Now I practice in a slightly different environment in that pretty much all of my patients are type 1 and type 2 skin, so it can be quite difficult to get them over that hurdle of the dryness. So I would always be combining actually dermocosmetics with my prescription therapies and ensuring that they're using things like ceramides after applying their cream. But I definitely think it's easier because of the single pump dispenser that you can say it's just one pump, don't put 2 or 3 pumps, less is more. So you can be quite clear and succinct and hopefully they do it.
I mean, it's true, the concept of sort of drying out acne, which I think was there a while ago, if you looked at all of the topical preparations, they are so much more hydrating with ceramides, and I think in terms of the microbiome and all of those aspects, it's incredibly helpful. Faisal, what about you?
I mean, fixed dose adapalene with benzoyl peroxide is still advocated by NICE as the first line treatment for acne, and it does have the advantages of not involving antibiotics. I think where my practice has evolved more recently is actually paying more attention to dermocosmetics and general skincare. If you look at many of the trials for topical retinoids, if you look at the control arm for them, there is actually a significant improvement in the acne just by using a basic cleanser, a non-comedogenic sunscreen in the morning and a moisturizer in the evening. So the first thing I say to all of my patients, if you take nothing away from this, this is the one point I want you to use. I want you to use something like a basic cleanser, CeraVe blemish control cleanser, for example, twice a day. I want you to use a non-comedogenic moisturizer in the evening. So the one I tend to recommend is the CeraVe PM moisturizing lotion, which has niacinamide in it as well. It's cheap, it's relatively inexpensive, and it's an easy sell for teenagers as well. And then a non-comedogenic sunblock like the La Roche-Posay Anthelios, the oil control version. So that would be my mainstay. The other thing is we do know now that acne is associated with an impaired epidermal barrier as well. So I tend to recommend that people put on a non-comedogenic moisturizing lotion before they put on their retinoid. So they should do that, I'd normally say 20 minutes beforehand, put 1 pea-sized blob of the fixed dose adapalene and benzoyl peroxide to cover the entire face and build it up slowly. So normally twice a week for 2 weeks, 3 times a week for 2 weeks, 4 times a week for 2 weeks until they're using it every night. And then if there are more, I suppose, motivated patients and people who are more interested, then you can look at more nuanced products for them. But a lot of the products in the, for example, the La Roche-Posay Epiclar range are absolutely great for that.
Yeah, no, I think you just absolutely nailed it in terms of the compliance is so important and actually explaining people how to use it. I think creams are very difficult. You know, people just get slung a tube of cream because everyone's busy, and it's not even like tablets where you can say, we'll take 1 a day. So actually explaining, I use analogies like things like, it's like exercising when you go to the gym, you can't suddenly bench press 100 kilos. And the teenage boys love that. And then you just sort of build it up very slowly. So I think it's really important to explain it to them. And I think many studies have shown that actually, if you take time to educate patients, give them the right products around it, that actually you do get better outcomes. So it's very important. Question again for you, Faisal, in the spotlight here. Hyperpigmentation in more sort of diverse skin tones. So post-inflammatory hyperpigmentation is one of the most difficult things I think that I see when I'm treating, and it does remain a really significant challenge. What do you think are the most promising advancements now that we're in 2025 to actually prevent, to effectively treat, and what sort of practical pearls can you share?
Sure. So the biggest growing population, the biggest growing subpopulation within the UK is the group of patients of mixed race origin. And many of those have pigmented skin, what we would, I suppose, historically have described as type 4 or type 5 skin. And the big problem for them are the dark marks they're left with following acne or associated with acne. I think one thing that is important to recognise is that all the dark marks aren't necessarily post-inflammatory hyperpigmentation, and around 10 to 20% of people who have the dark marks actually have active acne there. If you were to biopsy them, look under a microscope, there is active inflammation there. So the first thing, as with any form of hyperpigmentation, is you actively treat the cause of the hyperpigmentation. So if they have acne, particularly in people with darker skin, you have to treat it aggressively early on. So I tend to have a much lower threshold for moving up to isotretinoin or spironolactone if needed, and making sure they're on a topical retinoid, but making sure they are escalating that appropriately. Again, I'd go back to what I said before. They should be using a cleanser twice a day, a basic moisturizing lotion at nighttime. And then going back to Prof. Faisali's talk earlier, they need to be using sun protection. So protection against UVA, UVB, as well as visible light as well. The product I tend to recommend is it's the La Roche-Posay Anthelios UV Moon 400 Anti-Dark Spot. The reason being that gives you a great level of protection against UVB, UVA, visible light, and also has the melasil molecule in it as well. As well as stopping the acne with a retinoid, you're doing your basic skincare, you're sun protecting in the morning, then you think about using a depigmenting agent after that. And what is quite promising now is that all of the companies are now specifically looking at acne-associated pigmentation and looking at the effects of their products on that. Now, the largest study to date that I'm aware of has been done by La Roche-Posay with the Melasil molecule, I think, involving around 120 patients. So the way I tend to recommend that is that with their routine for acne, I'd recommend they use a few drops of Mela-B3 serum or Melasil morning and evening as well, but you could substitute that for other depigmenting agents as well. I think the other thing just to bear in mind is that typically when we're thinking of depigmenting agents, people often reach towards hydroquinone, but just bear in mind you can get a paradoxical acneiform eruption with that, so I tend to steer away from that for that reason.
Interesting. I was just about to ask you whether you commonly use any of the other depigmenting agents. What about Alison and Nikki? Do you ever use depigmenting agents alongside your...
Yes, definitely. I think Faisal makes a really important point that actually it isn't post-inflammatory pigmentation, there is inflammation there. We've done a little bit of work and you can see that there's inflammatory changes, so it's really important to actually target the acne in terms of actually trying to avoid pigmentation, because it can last many, many years. There's an Asian group of dermatologists who actually looked at pigmentation in Asian skin, found that some of the patients had it for about 5 to 7 years. So it's something we need to just think about when we see it very early on in the course of the disease.
I think truncal hyperpigmentation is particularly difficult to treat because it's difficult to then do post-procedural aspects, and it can be very, very widespread. So I think this concept everyone's echoing of really early treatment and perhaps lowering the threshold for systemics or other sorts of treatments that you would have.
The best treatment for acne-associated pigmentation is stopping it to begin with. So if you see someone with it, please just escalate treatment as quickly as you can. But bearing in mind that also a lot of the topical treatments that we commonly use in acne, so retinoids, benzoyl peroxide, can be irritant and also might induce post-inflammatory hyperpigmentation, meaning it's more important to actually be using a moisturising lotion and escalating slowly first.
Brilliant. So we come on to the topic of lasers. So we've seen new sebaceous gland targeting lasers, which are really generating a very significant buzz. How do you see that they're going to be integrated into mainstream UK dermatology, particularly with the challenges that we have with our healthcare systems? And do you think there are any particular patient groups which are ideal candidates for this? I'll start with you, Nikki, and then...
there's a lot of buzz around this at the moment. And there are, the first FDA approved, I think it's nearly 5 years now. We've had it in our clinic since it arrived Christmas week, but we didn't get to use it. So we've had it since January. And these are looking at wavelength of 1726 nanometers to cause that sebaceous gland suppression. And the figures that they're quoting is essentially up to 92% of patients would see an over 50% reduction in their lesion count. But unfortunately, for the majority of my patients, they're not looking for 50% less acne. They want no acne. So we're using them now. It's a short course of treatment. It's 3 sessions, essentially a month apart. So technically you can do it within 2 months because you do day 0, week 4, and week 8. So I think it's going to be for some people who are just adamant they don't want isotretinoin, they don't want any medication, they've tried the creams, for example, or they potentially don't want to go on birth control to go on something like isotretinoin, or we've a lot of young people who want to move to Australia for 2 years and they don't have time to do a course of treatment, so they want it to be done. But we're yet to see the long-term benefits. So as you know, we've had isotretinoin for over 40-something years. We've all that amazing data. Certainly, the companies do claim that there isn't the same amount of flares the way you might see at the beginning of isotretinoin, but not in our clinic practice. We've certainly had to add in some antibiotics for a lot of our patients because they do flare. And the pain that we were quoted was about a 4 out of 10. And that's not in our teenage patients either. So we're probably looking at about 7, 8 out of 10. So they say you don't have to use numbing creams and things like that, but actually we do. We can't get some of the teenage boys, unfortunately, through the course. And they're slowly making progress, but we're only 9 months out. So, I want to see them back at 12 months. I want to see them back next year. And so far in my hands, it's nothing so far is going to replace isotretinoin. But there are some other lasers that are coming out, some with gold particles for its anti-inflammatory benefits, and then there's some near infrared, which are looking at up to 80+% of patients that are having a significant improvement in their acne. But again, the cost is quite prohibitive for some patients. So it's in Ireland, it's €3,900 for the course of treatment. And obviously, a course of isotretinoin is a lot cheaper. So if somebody's sitting in front of you and has scarring acne, I want to hopefully be able to give them the cure, as opposed to say, let's spend almost €4,000 and I hope that it works. So right now, in my hands, it's not as good as isotretinoin.
I mean, it's interesting. Some of the studies have suggested that it takes up to 2 years to really see the maximum effect. And it's a hard one when you've got teenagers and people that want their acne better, a bit sooner. Yeah. But it's, Faisal, have you experienced it?
I mean, I've not personally used it myself. I think it is important to remember, though, that lasers aren't a new treatment for acne. So pulse dye laser, IPL, have been around for years. But when, even though rigorous cost-effectiveness analyses haven't been performed, we know that they're just not as effective as a good topical regimen, and certainly not as effective as isotretinoin. I think within the NHS in England, I think it's probably going to be limited to the private sector for the foreseeable future. And it's going to depend on whether the effectiveness trials are undertaken compared to, for example, isotretinoin. And also the cost-effectiveness analysis. And maybe with the increased paperwork of isotretinoin and blood tests and follow-up, maybe the case could be made for lasers to be more cost-effective in some circumstances. But those analyses, as well as long-term follow-up data, are yet to be forthcoming.
I mean, it's interesting you mentioned about pulse dye and IPL, because my understanding of it was that in some ways it was like the laser hair removal of acne. So actually what it does is to target the sebaceous gland to actually try and semi-permanently remove it. So I think the theory sounds good, but it's difficult to know whether this is another damp squib in the devices in acne, which I agree have been very, very disappointing to date.
Absolutely, yeah.
Perfect. So Alison, can I ask you about topical anti-androgens? So beyond sort of energy-based devices, we've got now newer topical anti-androgens which can offer a novel approach to acne. How do you see this fitting into our current treatment algorithms, and particularly for adult females, and what do you think their practical advantages are over some of the other creams?
So I think this is really interesting because it's the first time we've had a topical therapy that can reduce sebum. We've got quite a lot of topical therapies that will just reduce casual sebum on the surface, but this actually targets the androgen receptors, so actually reduces sebum production from the pilosebaceous follicle. So I think it's quite interesting. I haven't had a lot of experience. I've just started to use it. It's quite slow as monotherapy, but it does reduce inflammatory changes and it does reduce sebum. So talking to my American colleagues who've used it for a long time, because it's been around 3 or 4 years there, and Canada too, they're tending to use it as combinations. So with fixed combination products, I mean, they've got triple combination benzoyl peroxide, retinoids and antibiotics, plus the sebum reducer, and they're finding that very effective rather than actually having to use oral treatments. I can see it being very useful in adult females who've got that perioral distribution. It was interesting, we did a spironolactone study a while ago showing it was very effective in adult females, but when we did some subgroup analysis, and I accept it wasn't powered very highly, we showed that it worked better in adult females than it did in children, younger children, suggesting there might be a different end organ response in the androgen receptor. So this might be really useful for adult females. And Faisal and I were talking earlier, and he was saying he managed to take someone off spironolactone to use topical clascoterone, as it's called. So I think that's one area it'd be very useful. I think it may be useful for those patients who relapse post-isotretinoin. We know the younger a patient is, the more likely they are to relapse because their sebaceous follicles switch on asynchronously. So I think anticipating who might relapse and thinking we've got an anti-androgen to reduce the sebum production would be good. It may be useful in transgender patients who are taking testosterone. And I certainly think it's useful in combination with other fixed combination products. Thank you.
Do you have any concern about HPA axis suppression?
No, we've looked at that quite carefully actually, because actually the EMA were not keen on actually approving it So we actually looked at all the evidence, and there have been some small studies in younger children, because that's what they were worried in. But it wasn't founded that there was any problem. So I think certainly for facial acne, where you're only using it for a small area, I wouldn't be concerned. I think maybe if you're using it longer term on a larger area, the evidence to prove it's okay isn't there, but certainly for a localised area, I think you're okay, yeah.
Good. And what about its mild glucocorticoid activities? So on some patient sites like Reddit, people are talking about a topical, very, very scientific. Some people are talking about a topical steroid withdrawal-like approach to it. Do you think that's just...
I don't think that'll help.
Good, fantastic. So, Nikki, can I ask you about, on this topic, misinformation, of which there is a lot on Reddit, TikTok, Instagram, and the rest of the sites. So social media is really powerful, and I think it's been a great tool for patients to be able to talk about their different conditions, to advocate for themselves, but it is often a really misleading source of information for our patients. What actionable strategies can dermatologists employ to effectively counter this misinformation about acne, hyperpigmentation, sunscreen, and how can we empower our patients to become better informed consumers of skincare and healthcare advice?
Yeah, I think our job is getting harder and harder. We can't just be a clinician. We have to navigate this sea of misinformation. And as I was saying earlier, people are coming in armed with all of this. And certainly the younger generation, they're on every social media platform. So within our own practice, we've got 13 dermatologists together, and not everyone is equally as vocal on social media. And I'm not suggesting you all have to suddenly set up Instagram accounts and teach all of your patients, but that is what we do. So we have what we call our Ask ID, because our clinic is the institute. So we ask ID, and our patients will send in questions. And then between myself and our other co-founder of the practice, we will answer them. And then they're posted on our Instagram every week. And they're there to be educational. And we're also talk about dermocosmetics that go with medical conditions. So we do that every week. And then we have a special one now called Mythbusters, because there is so much misinformation out there. So we literally put up, the classic thing that you see on TikTok, and then we answer it and say whether, it's right or wrong. And then every week we are either on national radio or the newspaper with another, essentially, this is what TikTok said and what do you think? So we try our best to get out there with education to patients at that level. But in my own clinic, particularly with the teenagers, I'll usually ask them, particularly if you're discussing isotretinoin and things like that, it's like, so what have you heard, and what questions do you have in relation to that? And often they'll come out with the wildest things. And that's where I have a printout for everyone, and I will go through all of that with them. So I think it obviously depends on what your practice is and how much you're into social media, but I think if we can educate them, it's really, really helpful. And not saying, that's rubbish, you're not going to say it like that, but just to say, no, there are other ways to, to treat things or to do things. But yeah, we found it really helpful. The most positive feedback we get actually is thank you for your educational chat. And some of the videos are just 30 seconds.
It's fantastic, really good. So coming to the end of our questions now, Alison, I'm going to do you the penultimate one, ask you the penultimate one. How do we integrate holistic care? So we know, all of us as dermatologists know how profound acne's impact is on our mental well-being. How can dermatologists more effectively integrate holistic care, including psychological support, quality of life discussions, into our sort of routine acne management?
I mean, I see that as just part of what we should be doing. It's really what we've just been hearing about, this fantastic education. And I mean, there's actually an NIHR health technology assessment study being conducted at the moment through a program grant in Southampton called Acne Care Online, where they're working with patients to actually improve education and actually think about how we can assess them and what they need to actually support them. I mean, clearly acne is a profoundly distressing condition, and we know it lowers self-esteem, causes anxiety, even suicide. I mean, we've seen all sorts of problems from acne, haven't we? I think in terms of in clinic, you can use screening tools. Remember, they're not diagnostic, but they're screening tools, and you can use very simple ones and quick ones, just really to try and signpost you to where the problem is for the patients. I sometimes ask just very simple questions, how does it make you feel? what does it stop you doing, just to try and probe the impact that it's having and try and get them to open up. I mean, one of the problems we've got in the UK is that we haven't got psychodermatology and psychology support for everybody. It's a real postcode lottery, isn't it? And where it is there, it's very effective. But you can signpost to children and adolescents mental health services, GPs, obviously, I know they're very busy, but will actually support us in that as well. And I think there's some quite interesting apps in terms of CBT that you can actually use as well for patients. So I think it's just about remembering what a profoundly distressing condition it is, and that should just be automatically part of our management.
Very good reminder. So last question is really about our future vision. So I'll start with Faisal, but looking 5 to 10 years into the future, if you could advocate for one significant overarching change in the entire management paradigm of acne, what would it be? And what immediate steps should the dermatology community take collectively to achieve it?
So I would say it's focusing not just on the acne, but what might come next, so the post-acne sequelae. So whether that's post-inflammatory hyperpigmentation, which is often more distressing than the acne itself for many patients, or post-acne erythema, or even post-acne scarring, and thinking about those side effects now rather than in 5 years' time. And luckily, there are many good studies going on now looking at which topical retinoids may be helpful in reducing some of these sequelae, and which other dermocosmetics may be helpful in reducing those sequelae as well.
Fantastic. Nikki?
I'm hoping somebody's working on isotretinoin 2.0 with no controversy and no side effects, and I'm just going to be able to prescribe it.
Yes.
No, I'm really hoping that we can, instead of do reactive treatment for acne, which is kind of what we are doing, that we can kind of debunk some of the myths and start to be a bit more proactive about it, and stop that, the teenagers will grow out of it, if I hear that one more time, and that people will present a little bit earlier. So as Faisal was saying, we can get in there earlier, we can treat the skin barrier, we can, give all of these treatments that we have, as opposed to seeing patients, 2-3 years down the line struggling, and unfortunately, you're never going to give them as good skin as if they didn't have the acne and the acne scarring in the first place. So to just be a little bit more proactive rather than reactive.
I think that's really important. Alison?
I mean, completely agree with both of those comments. I think the other thing that would be really interesting is see whether we can personalise care a little bit more. We've got AI coming on board. I've kept an acne database for 20 years, and I've just been working with the data analytics team in York University, and we've actually fed in an AI model to demonstrate whether we can actually predict severity, because obviously we look at spots and we count them, but it's not very accurate, and it doesn't capture that holistic overview, in terms of mental health, etc. So we've actually come up with a model based on AI to predict acne severity. So that potentially could inform our treatments. I think the other thing that would be really interesting, and I'm thinking sort of from a scientific point of view, is whether we can identify biomarkers. So we've done a little bit of work looking at microRNAs and demonstrated that people who scar have a very different microRNA profile than those that don't. So wouldn't it be great to take a blood test and say, they're a scarer, we need to actually go for treatment that's going to treat them early and effectively, avoid sequelae. So I think there may be something really interesting in terms of personalising and tailoring treatment with our AI and all our technologies, digital technologies that are coming on board.
Brilliant. So hopefully 10 years' time, acne scarring will be a thing of the past.
Let's hope
That's
so.
what we're hoping for. I've got a couple of questions and then we will finish, but this has been absolutely fascinating, so thank you all. What are your thoughts on LED light therapy at-home masks?
So I think, I think there was a systematic review of these by John Barbieri in the States, and he found that they're very variable from model to model, but at best they have a similar effect to using a basic cleanser twice daily.
Love that, thank you.
So.
Anyone else?
No, some of my patients use the red light therapy for all sorts of reasons, but some of them have, and we see because of our type 1 skin, we see a lot more post-inflammatory erythema than we do necessarily hyperpigmentation, and some of them definitely use that alongside other treatments and they feel it goes away quicker. But, yeah.
Alison, any thoughts? Same.
Exactly same. I've got some people that use it and think it's wonderful, so I think if it helps them, it helps them, but I don't think the evidence for them is great, is it?
No. And topical metformin, someone asked about. Anyone use topical metformin? for acne?
We don't have it available, no. Yeah.
I've tried oral metformin
Yeah,
in case of PCOS, but that was alongside other treatments and not as a monotherapy.
Fantastic. Well, thank you so much. That was absolutely brilliant.